Thank you for joining us for OrthoAlliance's OrthoInsights educational webinar series on sports medicine. Tonight's speakers are Drs. Roberto Brandao, George Matic, and Mark Mendeszoon. Topics for the evening include common sports-related injuries of the foot, ankle, and knee. Speakers will answer questions following the presentations. Please type your questions in the Q&A box at the bottom of your screen. We will include all questions and answers on our OrthoInsights webinar series blog located at the OrthoAlliance website at orthoalliance.com. Our first speaker of the evening is Dr. Roberto Brandao, foot and ankle surgeon at Orthopedic Foot Ankle Center. Dr. Brandao is speaking on common foot injuries in sport. Dr. Brandao?
Thank you, Heather. Are you able to see everything, Heather?
Yes.
Great, thank you. All right, good evening, everyone. Thank you so much for having me. I've been tasked today to speak on some common foot sports injuries. I think it's really important to note that there's an old saying, everyone's an athlete, we're just at different levels. So some of these are not quite going to be in your pro sports, but maybe what we're doing at home or playing with our kids. Still a sport, so we'll get into a few here. Like Heather said, I'm from the Orthopedic Foot Ankle Center here in Columbus, Ohio. Also practice in Zanesville. So really common foot and ankle, foot injuries of sports really are going to be broken down into a few categories for us today. A lot of these are going to be in high school, youth sports. We see a lot of pediatrics in our practice at varying levels. But some of the ones I wanted to talk about today included toe fractures, a little turf toe, fifth metatarsal fractures, midfoot injuries or sprains, and then a little bit of pediatrics, at least the most common one that I'm seeing in my practice. These foot injuries in sports can happen at any age, especially with pickleball. I have a fun little slide at the end to talk about that as well. So first to start with toe fractures and turf toe, and I'll explain what those are. So toe fractures, I think a lot of us are familiar with. This is a really good example of what's called a bedpost fracture. Not so much in sport, but when you're walking around late at night, the lights are off and you hit that bedpost or you hit something and your toe kind of turns in a different direction. It can be very common in sport. You can hit something or someone rather, and these can vary for different severity, just jamming the toe or getting a fracture just like this. Luckily, a lot of these are treated without surgery. Sometimes they do need to be reduced or sort of put back in the corrected position here, as you can see on the left to right picture, and they heal very, very well. In fact, most people will not seek treatment. A lot of times I get patients say, I didn't even want to come in, I didn't know what to do. But that's always the patient that looks like this, and they definitely need your help. So the treatment sometimes really just can consist of taping. On very rare occasion, if it's a really bad fracture, we will put a pin or a very small screw in, but that's really only in severe cases, and usually the great toe itself. Most of the lesser toes, 2 through 5, do not require much to be done. This is a very simple example of someone. So again, athletes at a different level, but she was playing with her grandkids, tripped, fell, and hurt her toe, sort of pointing in a left field, as I like to say, or right field. And we reduced that in the office, and she's done very, very well. So just a small little example. A little more common injury in higher level sports that you'll see in your high school athletes or youth athletes, and even professional level athletes are going to be a turf toe, which is when your great toe really hyperextends and what's called dorsiflexes. So it's really when a cleat gets stuck and the body rolls over, or the foot rolls over it, or someone hits it or jams it just like your finger, but it goes in the opposite direction it's meant to. Luckily, again, here really can treat non-operatively. In some cases do require surgery that are high-level athletes, have retracted issues. Very successful and very common one was Patrick Mahomes recently, and obviously he's gone on to win a few Super Bowls. So that's a really common injury in soccer and football, in cleated sports. Next is fifth metatarsal fractures. These are really, really common. They're one of the most commonly fractured metatarsals that we see. They can happen during ankle sprains or falls, or sometimes even with ankle fractures. There's 3 really main types that we look at. One is a dancer's fracture, so named because it was very common in ballerinas when they landed and they have no supporting their shoe, obviously, in their ballet shoes. And then the other ones are avulsion, and we always hear what's called a Jones fracture. So we'll look at what those are and how we can better explain them. So this is a little color map of how to differentiate where they are. Avulsion, Jones, and then stress and or dancer's fractures is not listed here. But that's a really easy way to sort of know. And we base all these names off of these locations right here. So most avulsions and dancer's fractures heal very well. Again, dancer's fractures are the ones that are sort of in the middle of the bone there. They heal with rest, non-weight bearing periods. There's been a lot of studies about early accelerated weight bearing or weight bearing on your heel in a boot. I do that as well, and it does quite well. So some do require surgery. The angulated dancer's fractures, again, those are the shaft fractures, and then Jones fractures in athletes can return to activities quicker. So here's a young lady example. She was playing soccer. This is what's called sort of a dancer's fracture or a mid-shaft fracture of the fifth metatarsal that underwent plating and fixed. We don't really need to do this that often, luckily, but sometimes if they're severe, we do need to do that, especially if they need to return to activities quicker. This is an example of a young lady who had a Jones fracture, sort of in that standard Jones fracture area, that just did not go on to heal. And that's the thing with Jones fractures, is they do not heal well, or as well as the other types of fractures, even those other ones that are sort of shifted out of place more. So those sometimes require surgery. This was what's called a non-union surgery. So we went in, opened it, put some bone grafting, and then placed a screw across it. She healed very well. She's actually employed by our OA, and she's done very well with that. And she's walking around and she helps patients every day. Really famous ones. Right here, you have Derrick Henry a few years ago. Kevin Durant had one, and then Julian Edelman had one when he was playing with the Patriots as well. They take a long time in athletes to come back even after screw fixation, but these guys will return quicker due to motivation. Midfoot sprains, or what's called Liz Frank sprains, are when the middle of the foot twists. So again, really common in cleated sports, when the foot stays planted and then the body will twist or rotate. So for example, if someone's being tackled, but the foot kind of stays and the foot will rotate while the body gets hit. These are really, really common. They're also associated with metatarsal fractures. Really common in football and soccer. Some big ones recently when the NBA was Chet Holmgren. He was last year playing in his preseason game, and he had a Liz Frank rupture that had to be fixed. Cam Newton, in the last couple of years of his professional career, before he became a professional podcaster, had to sit out the whole year with a sprain and not requiring surgery on this. What you're going to see here is a lot of midfoot bruising. So whenever you see this, be aware. It's obviously going to come a few days later, so not on the field or anything like that, but we will review it with x-rays and CT scans and oftentimes an MRI to confirm the tear as well. This is an example of a young man playing soccer, and you can see here the gapping on the picture of the left, and the metatarsal is kind of lifted up above the rest of them. That's an indication that there's a complete rupture. There's also some small associated fractures there. He underwent a primary fusion and realignment of those joints for Liz Frank fracture surgery and Liz Frank sprain. The last one, and the most common one that I see, is Sever's disease, or calcaneal apophysitis is really the more generalized term for it. You're really going to see these in young people 9 to 13 playing soccer. It seems to be the cleat, it seems to be the activity, it seems to be the low level of the shoe without a significant heel. You'll get some swelling, redness. I see this. I'm surprised. I saw this a lot more in August, September, early October, but seeing a little bit less of it. This is really common in the fall, and then again kind of in the spring after we come out of hibernation in the winter. But really, you'll notice like it's really just painful with activity and immediately following an activity, but they're not painful all the time, and it tends to get better. So what we do with this is take some x-rays, take a look at it. Everyone's, for different types of people interpreting the x-ray may look broken back there, but that's actually just a normal growth plate that's going to eventually lay down bone and heal, and will rather become the growth center and then just become the whole heel bone. So the real treatment here is patience. It's very self-limiting, and it will get better with time and age-appropriate NSAIDs like oral anti-inflammatories and heel lifts. Last sort of quick slide here, just sort of talking about sports throughout ages and foot injuries. So pickleball is booming right now. They're expecting 40 million people by 2023. And a lot of these injuries, as you can see, are lower leg, lower trunk, ankle. They don't do a lot of, the ratings that really talk about foot. They just sort of generalized a lot of it, but also knees and other things to talk about. But I just thought that was really interesting as we're looking at who is playing pickleball, as 1/3 of them are over 65 as well. So, thank you.
Thank you, Dr. Brandao. Next, Dr. George Matic, Beacon Orthopaedics and Sports Medicine orthopedic surgeon, will discuss the use of orthobiologics in knee injuries. Dr. Matic?
How are you guys doing? Can everybody hear me okay? Hopefully. I will.
Yep.
Just a second here. All right. I am a primary care sports medicine physician at Beacon Orthopaedics. So I've been tasked to talk about some knee injuries and really specifically orthobiologics in knee injuries. So this is a topic that probably many people have heard about. Kind of want to give some more information on that. I am a consultant for Arthrex, where I get most of my orthobiologics from. So I just wanted to disclose that. So brief kind of introduction on orthobiologics. So orthobiologics, are our own kind of bodies, substances that allow us to heal. Most commonly, we'll hear about platelets. They are typically used to treat musculoskeletal injuries, bones, muscles, tendons, ligaments, cartilage, etc., that are injured. So some terminology that you may come across as you look into biologics. Autologous means that it comes from our own body. So when we're getting blood, when we're getting stem cells, etc., they're coming from ourselves. If they're coming from another source, you think about it as allogeneic. So most commonly they're injected. That's usually how we get them to the site. So when you think about like a knee injury, whether that's in the joint or the surrounding soft tissue, usually the kind of best way that we can get it there is via injection. And usually that's used for non-operative management. However, in surgery, biologics are used quite frequently. And so definitely can be surgically implanted as well, whether that's done at the time of surgery via an injection or some type of graft tissue that they use in surgery. So, as you're getting treated for any type of knee injuries, and people bring up biologics, these are kind of the typical terminology that you may hear in terms of products. So PRP is really the most common one that we see. It's a blood draw that it takes your own blood. It spins down in a centrifuge, and what it does is it concentrates those platelets, and we then use those platelets to help promote healing and decrease inflammation at the site of injury. Stem cell therapy, I usually use that in quotation marks, so stem cell therapy. So we do have stem cells that we can harvest, and usually that's harvested via the bone marrow or our own fat that also has stem cells in it. They have a lot of early cell signaling, which can be very helpful to recruit healing cells to that area that's damaged. And so, stem cells do work really well for that and helps kind of regenerate injured tissue. A lot of times we use stem cells in conjunction with platelets. Hyaluronic acid, those are, you've probably heard of them as the chicken or rooster injections. They're basically a lubricating injection. Those are made up of hyaluronic acid, which our knee joints make to help lubricate the joint. So it's naturally occurring. we can add that in to the joint to help decrease pain and improve some inflammation. We naturally make that, and as the body starts to get arthritis, it starts to actually break that molecule down. So sometimes adding that back in can provide us with some better relief. So kind of before we go into depth more, I do want to make sure that we talk about it. It is an out-of-pocket type of procedure, and so when you're hearing about this from different practices, and they start talking about this, there is a cost to that. Very rarely do insurance companies approve this. I probably get the most coverage out of workers' compensation, actually, as opposed to private insurers. The average cost of PRP in the United States, especially on the East Coast, ranges from about $500 to $2,500. Really, probably the average kind of is somewhat in the middle. Anywhere from really about $700 to $1,000 is what you'll see it for. The bone marrow, which is the stem cell treatment, that is much more variable. You can see costs upwards of $2,000 to $50,000, which I think when you're going that high, I think you probably need to question where is this coming from, and why is it costing so much? Because that's a pretty large number in range. It should really be in that lower thousands range, as opposed to that upper echelon. So common knee injuries treated with biologics. So probably these are the most common ones that we see. We do a lot of biologics for knee osteoarthritis, meniscus tears, ligament injuries, more so MCL than any other ligament in the knee, as well as tendon injuries. A lot of times the patellar tendon is probably the most common one that we treat in the knee. So talking about a little bit of arthritis. So, the big thing with arthritis really is, you get some breakdown of cartilage, and that's, the best way I kind of describe that is, if you look at a chicken wing, at your restaurant, and you take off all the nice meat of that chicken wing, you're left with this bone, and you've got that nice pearly kind of appearance to the end of the bone. That's the cartilage. If you take some sandpaper to that cartilage, you're essentially creating arthritis. And so we are essentially breaking down that cartilage in our bone, and that's what leads to the arthritis and just overall pain. So, end stage arthritis, you're thinking, more of knee replacement. However, in athletes, people that want to stay active, young and old, we really, obviously want to try to keep as much of our native parts as possible. So different options for knee arthritis, including injections, and PRP is definitely one of those. And so that can simulate a little bit of cartilage repair, and some of those kind of focal defects that we see in the cartilage can do a good job of trying to fill that in. When they've compared those to what most people know of as cortisone injections, or those hyaluronic acid, those gel injections, they've actually been shown in some high-level studies to be given better pain and functional outcomes. However, the caveat to that is best for patients with mild to moderate arthritis. I see a lot of patients that come in and they've been to different places that are kind of offering these biologics, and they have bone on bone, arthritis. Unfortunately, you're not going to get that kind of relief that you're looking for with a PRP injection. However, if you have more mild to moderate type of arthritis, you're still very active, you're playing sports, pickleball, you may be a very good candidate for PRP to hopefully provide more longer term relief than maybe a steroid injection. So meniscus tears are another area that we can potentially try to treat non-operatively. It really depends on the type of tear that is present. A large tear that is, flipped into the joint, what we call a bucket handle tear, that is not something that you can try to treat, necessarily non-operatively with a biologic. Most of the time they require surgery. However, when you repair that meniscus, it actually has been shown to be very helpful for the healing rates of those meniscus, because meniscus in general don't have a lot of healing potential. So adding a biologic to that, such as PRP, really can minimize the risk of failure from that repair and can improve overall outcomes. Meniscus tears that are more degenerative in nature, so patients that may have some early arthritis, actually do very well with PRP, and they've been studies to show that it can be 6, and 12 months they've have better overall pain and functional scores when compared to kind of your normal steroid injections, for instance. So a lot of people have meniscus tears. A lot of people that have meniscus tears do not need surgery. A lot of patients want to not undergo surgery, and trying to do a biologic may provide some healing to that and allow you to return to your activities. So ligament injuries, MCL is probably the one that I treat the most in terms of biologics. Most ACL tears, if you fully tear your ACL, will require surgery, especially at a younger age. As we get older, we don't always have to treat ACLs with surgery, as long as you're functionally stable, able to get back to your activities. But these lower kind of to intermediate grade MCL sprains, where you have some partial tearing, really do very well with biologics, and it has been shown to actually cut recovery time in half. Probably most famously was one of the wide receivers for the Pittsburgh Steelers years ago, had PRP for his MCL sprain and was able to play in the Super Bowl. So they do help provide some more stability as you let that ligament fully heal, and allow return back to really the majority of your activities prior to that particular injury. Patellar tendon injuries. So a lot of times we see tendinopathy, which is basically kind of chronic changes that happen over time. And in this kind of little diagram, you can see what a normal tendon looks like. Nice fibers, to where you get more of an inflamed tendon, to where you have not necessarily a torn tendon, but kind of more degenerative in nature. And PRP does a really, really good job of allowing those to kind of heal. They compared those to just kind of a normal saline injection, and had significant more improvements at 6 and 12 months with a biologic. And this can really be helpful really all over the body when you talk about tendons and tendinopathy, which are kind of degenerative changes, again, in the tendon. We see it a lot with our athletes, especially, our middle-age athletes. They'll have some of these issues, and really being able to provide a different type of treatment for these that are non-surgical is really beneficial. And I think a lot of people are not looking to have surgery on these. A lot of surgeons are not looking to do surgeries on these. They try to kind of continue to treat these non-operatively. And so a biologic to this type of injury can be very, very helpful. So those are kind of the main things that we treat in the knee. So how do these compare to some of the traditional, treatments? Again, surgery is warranted in certain cases. If you fully rupture your ACL, you're not going to get that to heal, with a biologic. But maybe a low-grade sprain, when you add a biologic, it can be a quicker recovery. Obviously, much less invasive than opening you up and doing a surgery. It's usually a needle poke done under ultrasound guidance, so that we can see exactly where we're injecting, or some type of X-ray guidance. When you look at those via biologics versus steroid injections, especially for knee arthritis, it's been shown to promote healing rather than just kind of decreasing kind of pain and inflammation. And I think ultimately, if you're trying to avoid a knee replacement down the road, if you're trying to recover to get back to your sport activities, you really want to promote healing rather than just limit your pain. And so the biologics have been shown to do that very well. When we look at biologics versus physical therapy, in fact, most of the time I use those in combination. So most of the patients that I do biologics to are likely going to get some physical therapy along the way. Really, no matter what I'm treating, I think when you add those in conjunction with one another, the outcomes tend to be much better. So, we're already using physical therapy for movement, strength, mobility. If you can enhance some of the healing process in addition to that, then I think you get a much better benefit. So some expected results. So really trying to keep realistic expectations on what that looks like from a healing standpoint, I think is important. So, you are setting off a kind of a more of an inflammatory response initially. And so a lot of people can have initial pain within the first 24 to 48 hours. And that's just kind of that initial response to the injection. And then after that, it kind of the inflammatory response starts to die down. People start to have kind of a back down to almost baseline symptoms. And then really after that first week is when you start to maybe notice a little bit of gradual improvement as the reparative process of the tissue starts to take place. And then really, I tell my patients around 6 weeks is when typically you'll start to feel improvement. You're likely not 100%, but you are having less pain with the activities. Maybe you're waking up with less pain. The going up and down the stairs that was once really painful for you is doing better. You're feeling more stable if you're treating a ligament injury, etc. And really, I tell them in about 2 to 3 months, you are likely not even thinking about that injury anymore. You are kind of getting back to all of your activities and saying, hey, I didn't even realize that I've had this injury. And then I really tell them, long term, it actually can continue to cause improvement. It can continue to help remodel that tissue, especially with a good rehab program. And so long term, you want to continue to do what you need to allow that tissue to heal fully so that you get that long-term benefit for the biologic. And again, especially, as we talked, it's an out-of-pocket cost. So really what you're doing is really adding to that, hey, I'm going to pay the money for this. I'm going to invest in this for myself. And so you want to do, everything, the right way so that this thing heals appropriately. So this is kind of a busy slide, but I think it's helpful, when people kind of see, why does this take so long to heal? And so kind of the rates of tissue healing, if you really look, when you talk about a tendon, for instance, a chronic injury, somebody that's been dealing with something for a longer period of time, you can see that, it can take anywhere from 3 to 18 months to get better. And so, when people are like, why are my, tendons not healing quickly? It's just not the way the body normally does it. Now, biologics have been shown to enhance that and speed up some of that recovery. And so hopefully can get that where people get back a little bit faster than what the normal body is going to do. So it's kind of interesting to see how some of these different body parts kind of heal and the timeline that it takes. And I think it provides people with a realistic expectation when you're talking about treating with a biologic. The safety profile, most people are going to wonder, is this safe? Is this, is this going to cause any problems? And the reality is, you're using your own body to heal, and so you're not injecting anything foreign into the joint or into the soft tissue that you're treating. And so very safe. And again, minimally invasive. Most of what we do is under ultrasound guidance. And so kind of getting it right to the tissue in the right spot. Side effects, like any injection, can just be swelling, some soreness at the injection site. And like we talked about, that initial, few days can be painful. from that injection, from the activation of the platelets. So just kind of going through who a good candidate is. So people, again, early changes in the joint can benefit much more than those that have, bone on bone type of arthritic changes. Soft tissue injuries such as tendons and ligaments. Those that have an injury that may not need surgery and are looking for an alternative to surgery. Those that may have said, gone through the normal conservative treatment options, such as, anti-inflammatories, physical therapy, bracing, and just not getting a full recovery, may be a very good candidate to add in a biologic to see if we can get some better healing. Those that are very active, I think benefit the most, and having the right expectations, a healthy person. Those all are the people that I think are the best candidates for biologics. I always kind of tell you, if you get what you kind of produce, and so if you're a healthy individual and you have healthy cells, healthy platelets, healthy stem cells, then those are going to work much better than if you're not as healthy in that regard. So kind of just to wrap up, so definitely options from non-surgical to treat some knee injuries. You can supplement surgeries with biologics. You are using your own body's ability to promote healing, and it does help improve overall function, and sometimes does accelerate some of that healing. And so those that are seeking to avoid some surgery, or if other treatment options have failed, may be a good candidate for that as well. So biologics are definitely, they've been around. I think they're under a lot of investigation, and I think they'll continue to advance, and we'll be continuing to use them more and more for a lot of these injuries. I appreciate it.
Thank you, Dr. Matic. Our final speaker of the night is Dr. Mark Mendeszoon, foot and ankle specialist at Precision Orthopaedic Specialties. Dr. Mendeszoon will address common ankle injuries in sport. Dr. Mendeszoon? We can't hear you, Dr. Mendeszoon.
Okay. Good evening, everyone. So I want to continue talking about common ankle injuries, and this is a very busy time for doctors and trainers as we are experiencing people with every sport. It's football, baseball, basketball, soccer, cross country, ice hockey, cheerleading. So our offices are pretty busy with common ankle injuries, and all I want to do today is just talk.
Dr. Mendeszoon, you're muted again. You're still muted, and your presentation is no longer on.
How about now?
Now we can hear you.
Okay, and I gotta just try to get back to the lecture. Technology, great. All right, let's see something here. And the screen is, all right.
We can't see your lecture if you.
Yeah, I'm working on that. Sorry about that. Give me 1 second. Zoom, share screen. Okay, can you hear and see me?
Yes.
Sorry about that, everyone. So I just want to briefly talk about common ankle injuries. The previous doctors mentioned certain things that they have seen. And now that we're in October, November, we're seeing practically every sport at every level. It's baseball, football, basketball, soccer, dancing, cross country, ice hockey. So we're seeing a lot of people. And I want to talk about some basic definitions because I think there's a disconnect when people have an injury and they go to the emergency room. And I want to explain what a sprain is. A sprain is when you damage ligaments. Ligaments are ropes that keep our skeleton together, and they only have so much ability to stretch out. And when there's a violent force applied to the ligaments can start stretching out or tearing. So if someone just tells you that, hey, it's just a sprain and you'll be fine, you definitely want to have a specialist look at you because sprains can lead to severe arthritis down the road. A strain is when you damage muscles or tendons. That means you stretch those out. Those are generally structures that have a little bit more flexibility. Muscles have better blood supply, so they can generally heal a little bit quicker. And tendons have a little bit more collagen impact, so that there's more stretchability, elasticity, so that they allow like a rubber band for the body to move. Sometimes people come from the ER and they say, hey, they told me I have a fracture, and you tell them you have a broken bone. It's the same definition, and we'll discuss that briefly. And lastly, if you ever hear or see some athletes or yourself, if someone has an injury, you can dislocate a joint. And that basically means a joint is popping out of the socket. So the ankle is one of the most common areas where ankle sprains are damaged, and ankle sprains are one of the most common areas that we can start tearing ligaments. And this slide basically shows you on the outside of the ankle, there are about 3 ligaments that really hold the ankle from going inward. If someone falls, if someone is unexpected, ligaments can only resist so much pressure before they tear. Over time, those ligaments can tear and even pull bone apart and causing for some really bad injuries. So please appreciate that ligaments, once they're damaged, it can cause for problems down the road, such as instability, can't go in heels, sometimes walking down steps of stairs. A lot of people who have bad ankle injuries that are neglected will lose balance issues and can't stand on one leg. So if you notice an injury, it's important that if you go to the ER, follow up with a specialist. An ankle injury will usually present like this picture. You're going to have significant pain. You're going to eventually get bruising, and that bruising will get worse over time. So usually around 3 to 7 days after original ankle injury, you'll start noticing more pain and swelling. You'll get guarding. You'll start losing motion of that ankle. And even in some situations with a bad ankle sprain, you can damage the nerves. The nerves can get stretched out, and it can persist with a little bit numbness and tingling. When somebody comes in with an ankle sprain, we always should take an x-ray because it's not always the bones that are injured. The ligaments can be damaged. The doctor should be able to evaluate the ankle and do some testing to see what the integrity or what the strength of the ligaments are and how flexible they are or how guarded you are. And if the ankle x-rays do not show any significant damage, it's going back to seeing how much bruising and swelling there is. People who have increased pain, increased swelling, shows us the severity of the ankle ligament is going to be damaged. There are 3 degrees of ankle sprains. First degree, which you stretch them out. Most people will get back to activities with a brace within 2 to 3 weeks. The second degree is where the ligaments are partially torn, and that can take anywhere from 6 to 3 months to get back to some type of good activity if you're an athlete. And then if you completely tear a ligament, that's a 3rd degree injury. And you can tear it completely in the mid-substance of the ligament, or you can pull it off the bone. Sometimes we do advanced imaging like this MRI, and it can tell us if the ligaments are torn, if the bones are bruised, and also tell us if there's swelling throughout the joint and look at the tendons. So MRIs are very helpful in determining if somebody may need long-term immobilization, physical therapy, or surgical intervention. Stress films. A lot of times people will guard. You can't really do this when they're awake. So if I take someone to surgery, even if the MRI shows normal ligaments and someone is struggling and they have balance problems and they have continued issues, a stress film will tell us the integrity of the ligaments, and that will tell the surgeon what needs to be done from a surgical perspective. Treatment options for ankle sprains: immobilization, physical therapy, bracing, regenerative medicine, and surgical intervention. Not everybody needs surgery and not everybody needs casting, And you have to really look at what sport the athlete is doing, how active they are, how old they are. And as mentioned earlier in today's series of lectures, children are treated definitely in a different light than adults because they have growth plates and bones are developing, and you don't want to damage them down the road. Another injury we'll talk about, they were talking briefly about patella tendon. The patella tendon and Achilles tendon are pretty similar in their construct. They are very large, strong tendons. They don't have the greatest blood supply. And when you injure a tendon, that is called a strain. You can stretch it out, you can partially tear them, or you can completely tear the tendon. In some situations, I wish people would completely tear their tendon because when they have a partial tear, they neglect the Achilles, and over time, the Achilles tendon will start to lay down scar tissue. And the more scar tissue that the tendon develops, you'll start noticing a bump or a bulbous-like swollen part of your Achilles, and you'll start losing strength. You'll start having pain. And then if you look at someone on an MRI, they're going to have chronic scar tissue. So the mobility, strength, and flexibility of the Achilles is diminished. And that could be more painful than an acute injury over time. So if you're having pain or discomfort and someone tells you that you hurt your Achilles, the treatment will be very similar to ankle injuries, but I definitely recommend having immediate evaluation by a medical specialist so that they know what the proper treatment is to prevent long-term problems. This is an MRI, and you can see the gap where the black structure is. An Achilles tendon should be continuous. If someone has a complete rupture, then unfortunately, that person will need surgical intervention, and there are many ways that you can repair an Achilles. Treatment is immobilization for partial tears and strains. Try to catch them early. Aggressive physical therapy, regenerative medicine, and then there's surgical intervention. Acute injuries, such as an acute tendon tear, Achilles tendon tear, typically will need surgery if the person is athletic. If it's a partial treatment, there have been some new minimally invasive techniques that can help with chronic scar tissue in the Achilles tendon, combined with regenerative medicine, and a lot of times people can avoid a major reconstructive surgery. When someone tells you that you have a fracture, that means the bone is broken. But what you have to understand that when we see people with ankle injuries, it's not necessarily the bone that will be the limiting factor in how well somebody does. It's the ligaments that are damaged. If I look at this x-ray right here, we can say that, okay, 2 bones are broken, but in order for that x-ray to sustain that type of appearance, we know that there's a physical attribute and mechanical inclination for that type of fracture to develop. And ligaments have failed and have torn, and this ankle is very unstable. And if this ankle heals in this position, this person will unfortunately wind up with the ability of not walking or may need an ankle fusion. And in some situations, if the ankle's in good alignment, down the road, if arthritis is very bad, they may need an ankle joint replacement. So ankle fractures are not just with broken bones, but to sustain a broken bone, there could be soft tissue involvement. And yet again, see a specialist for that. And we talked about ankle fracture treatment. You can see this is a pretty bad fracture, needs a lot of hardware, needs a lot of fixation. And even though this may look good as a repair, most people with these type of high velocity injuries and this pattern of injuries do not do well long-term. And this patient may need special bracing. They may have stiffness in their ankle. They may need more surgery. And ultimately, they may need an ankle joint replacement, ankle joint fusion. And if this person has some issues, and if they have complications, an amputation is even a possibility from these horrible injuries. And last but not least, ankle dislocation means that the joint pops out of the socket. And if that joint pops out of the socket, that is immediate surgical intervention, or you have to reduce that fracture. Otherwise, a person can lose sensation, the blood supply can be compromised, and you can start losing blood flow to the tissue, and that is not a good thing. So if an ankle dislocation comes to the ER, hopefully the emergency room people can relocate it under some sedation, pop it back into place so the blood flow and nerves won't be damaged long-term. Dislocation treatment needs immediate attention, and the reason being is that the blood vessels in the nerves can be compromised, and if they're compromised too long, person can lose their foot and ankle or an extremity if something like that happens to the upper extremity. So in summary, these terms are very important to understand. Once again, quickly review, ligaments are the ropes that keep our skeleton together, and they only have so much ability to stretch, and if the forces are too great, they're going to tear. And depending on how badly these ligaments are torn, at what degree, first, second, or third degree, will indicate how long somebody will need before they're out of competition, if they can go back to work, if they can do normal activities. Seeing a specialist is very important for that. Number two is that when you strain muscles and tendons, generally those recoveries can be a little bit quicker because of the formation of collagen and blood supply, but also needs medical treatment. A fracture equals a broken bone, and a dislocation is when something pops out of the socket. Seek professional and expert care immediately for those conditions, especially if you go to the ER. Proper and early detection and treatment can reduce complications, and do not self-diagnose and treat. And lastly, try to avoid Dr. Google if there is a medical emergency or an injury that requires emergency room treatment. Thank you.
Thank you, Dr. Mendeszoon. If you can go ahead and stop sharing your screen, we have a few questions. The first question is, can PRP be injected more than once for a particular condition?
So yes, a lot of times we can do multiple injections, and a lot of times I'll start with one, and if you respond, but maybe still have a little bit of discomfort or maybe hit a plateau, then that would be a very good, you'd be a good candidate for maybe a second one or even a third one to get that full healing, or depending on what you're trying to treat, if it's a large enough injury, large enough tear, but still not operative in treatment, then yes, you can do kind of multiple rounds of PRP.
Thank you. What is a high ankle sprain?
Good question. A high ankle sprain are the tissues between the small bone, the fibula, and the tibia. And there's generally 5 ligaments that keep those bones together. So recently you'll hear athletes, especially football players, hockey players, they have a high ankle sprain, and it's between the little bone and the big bone where that tissue keeps the 2 bones together. And if those ligaments are torn, you're going to get a separation between the bones, and that can cause for some significant instability and arthritis. So MRIs can be helpful, but there's some clinical findings that you can look on X-ray. And if there is a high ankle sprain, and if the person is athletic and it's unstable, generally those people will benefit from a surgical procedure. And you may have heard of a procedure where they put a special type of button and suture to squeeze the bones together. And that's what you generally want to do in athletes. If somebody's not athletic, sometimes it would require plates and screws. But in a high ankle sprain is above the ankle where it keeps the 2 bones together.
What is the most common lower extremity pickleball injury?
Oh, thanks. Actually, from what I've looked in the literature, it's actually usually an ACL. So a little bit outside of my expertise, but it's actually an ACL. What we see the most in foot and ankle is definitely, I would think Dr. Mendeszoon would agree, would be an Achilles rupture, more than likely, or maybe a metatarsal fracture or a simple ankle sprain. But in the lower extremity, in total, it's an ACL currently in the literature.
Agreed. It's ACL, Achilles, and then the biggest problem with pickleball, people don't think it's a very quick sport and intense sport. And what we all see is that people don't warm up properly and they don't cool down. And, that weekend warrior effect can affect the Achilles, or we see 5th metatarsal Jones fractures from the way the foot may not be in a proper shoe. So it's important to stay in proper shoes if you're doing pickleball or tennis.
If I have a torn ACL, will an orthobiologic help it heal without surgery?
So again, ACLs, when you think about how an ACL tears, most of the time it'll completely rupture. And so you think about like an ACL almost tears like a mop head. It just kind of kind of explodes and those fibers are no longer intact. And so if that's the case, you're not going to be able to get those fibers to get back and heal, like a native ACL would, just using a biologic alone. And those ones usually, if it's a fully torn ACL, require reconstruction. Again, if you're young, athletic, functionally unstable, as we get a little older, we don't necessarily have to repair those ACLs all the time. It kind of depends on your overall stability and kind of the activities that you're trying to do. Some of the lower grade sprains, you can have a low grade sprain to the ACL. Those you can treat with biologics to try to kind of enhance some of that healing.
How long is the recovery for turf toe?
It can vary for a very, very long time. Simple sort of lower grade tears can be something in the neighborhood of a few weeks to a few months. Surgical repairs can be quite extensive, 3 to 6 months, maybe even a little bit longer. Really varies on the complexity and what you did at the time and how much of the apparatus, as we call it, got pulled off or ruptured.
What is worse, an ankle fracture or a severe ankle sprain?
They both stink. And I would say that a lot of times you see both. For a severe ankle fracture, you're going to see a lot of ligamentous damage. And as we always tell people, it's not the bones. We can do a really nice job putting the bones together, and it may look good postoperatively really well. But in my experience, I see that a lot of ankles that look great on x-ray fail because of the soft tissues. The ligaments are not properly repaired. So I would tell you that severe ankle injuries, fractures, have soft tissue ligament damage, or where the tissues are torn or sprained, and that has to be very important to repair. And a severe ankle sprain, if neglected, 10, 15, 20, I've been doing this for 30 years. People come back and say, when I was in high school, I had a bad basketball injury, I neglected it, and now they come in and they have bone-to-bone arthritis. So I think they're both evil in their own way. And once again, I think I can't emphasize having that so-called simple sprain or simple fracture evaluated by an expert so that you can get early recognition and treatment to hopefully prevent long-term problems.
Do we have any additional questions? Thank you very much to the speakers. This concludes our educational webinar series on sports medicine. All recordings will be available on OrthoAlliance's YouTube page at youtube.com/@OrthoAlliance. Thank you for joining us tonight and have a good evening.
Have a good evening.
Thank you.
Bye.